morning session. And the first talk of this half part is Suzan Farhang-Sardroodi.
Yes.
From University of Toronto. Welcome. I give time to go back to you. Yeah.
Thank you so much. So good morning, everyone. My name is Suzan Farhang-Sardroodi, and I am a research associate at the Department of Pharmacology, University of Toronto. I'm really honored to be one of the speakers in this incredible conference. Today, I would like to talk about chemotherapy-induced cachexia and the model-informed dosing to preserve limb mass in cancer treatment. So we published this paper in 2022 when I was postdoc at the Toronto Metropolitan University under the supervision of Dr. Wilkie. The research goals of this project was to mathematically model of chemotherapy-induced muscle loss that manners the nonlinear dose response of a skeletal muscle to cancer treatment, cancer chemotherapy treatment. We explored different dosing schedules. We investigated aging effects, and we studied the morphine use in chemotherapy treatment with the aim of better protecting the limb mass and also targeting the tumor burden. So at the beginning, I would like to talk about an introduction about cachexia. So cachexia is the debilitating conditions. It is a multifactorial syndrome that is defined by ongoing loss of skeletal muscle and adipose tissue. It is very common in some cancers like pancreatic, gastric, and lung cancer, and also some other diseases like the heart or the HIV. But also, it is the main side effect of the chemotherapy. We know that chemotherapy is the first line treatment of the cancer, but it has a very main side effect, which is deadly, and it reduces the patient's quality of life, which is the ongoing and irreversible muscle loss that is happening during the chemotherapy. As I mentioned here, it is an imbalance between anabolism and catabolism. It means that there is an increased catabolism and decreased anabolism is causing cancer cachexia. It is not just only the nutritional factor. So some agents like cisplatin and also 5-fluorouracil are causing cachexia, which our main focus in this paper was 5-fluorouracil. We started by investigating the preclinical data for CDF1 made mice, and we looked at the limb mass based on time for different drug schedules and different doses of the fluorouracil. So we started two different schedules. The first one is the daily schedules, which has a drug administration during the day in a week. And we can see in this figure that the most tolerable dose in daily schedule is the 29 milligram per kilogram, which is this purple curve. And more than 29 milligram per kilogram for 5 mice are dead. So this is for the daily chemotherapy. If we look at the 5 days on and 2 days off the chemotherapy, which is less frequent in comparison of the daily injection. So again, we can see the nonlinearity behavior for limb mass in terms of time for different amounts of the doses. But in 5 days on and 2 days off, the highest tolerable dose here is 42 milligram per kilogram. You can see this is the red curves there, which is about in the homeostatic level. It's like in the control state. So the drug injection is from day 0 up until day 27. And after day 27, when we stop the drug injection, the muscle mass comes back to the control level, which is the black curve there. So then we can conclude that in the 5 days on and 2 days off, the highest tolerable dose is higher than the daily one, which is the more frequent. So after looking at the preclinical data, we tried to develop our mathematical model. Our mathematical model has different parts. The first one was to look at the pharmacokinetic of the 5-fluorouracil as one of the chemo agents. So we looked at the, as a structure model, we looked at 2-compartment model, including the central and peripheral part, and also with only we have the elimination and also transition between these two tissues. And then using the ODS, we can model this pharmacokinetic. And also here at the end, we use the delta Dirac train in order to simulate the Dirac injection at different time points in this model. So this is for the pharmacokinetic model. Now the next step is to look at the muscle fibers and simulate the muscle cells. So in our simulation, we only considered satellite cells and the muscle fiber, and we ignored other precursor cells. Using ODE equations, we assume that the stem cells or satellite cells in the skeletal muscles are start proliferating with the self-renewal probability of P, and then they are doing the division by the division rate of nu T. They are dividing for the muscle fibers, and also we have assumed the one last term for the muscle cells. But as clearly explained with our first speaker in early morning, so there is a negative feedback when the muscle fibers are increasing. So the systems would like to come back to the homeostatic, to the steady state. So the stem cells, how we can simulate this negative feedback, we use the Hill function here. That so this is the steady probability, and then P1 is the perturbation probability, which is divided by the muscle fibers. The more muscle fiber that we have, so this term is going to be 0 and comes back to the steady state. So replacing these equations, we can simulate the healthy myogenesis in our system. The next step now is how we can incorporate chemotherapy effect, how we can incorporate the muscle loss in this system. So from biology, so if we look at the chemotherapy effect, as I mentioned, cachexia is common in cancer and chemotherapy, but the signaling pathways that are causing cachexia in cancer and chemotherapy are different. In chemotherapy, actually, we can see that the chemotherapy is affecting the mitochondrial, and also it's causing the toxicity and the dysfunction of the mitochondrial. And again, from biology, we know that mitochondrial metabolism is a key regulation of the stem cell activation, proliferation, and differentiation. So since mitochondrial activity is impaired, so we can simulate we can add some terms in order to reduce this probability and this division rates. So we added 1 minus cubic term, which is multiplied by the proliferation terms of the satellite cells and the differentiation of the muscle cells. So in this way, so that in this term, YT is the T average exposure of the tissue to the drug concentration. And we have 2 different parameters here, which is tau and RD, which are fitted in our model, 2 main parameters that we fitted in our model. And the last step in our model was to how we can actually simulate the tumor growth equation. For the tumor growth, we use the exponential linear tumor growth equation, as you can see for the first term in this ODE. And in order to simulate the tumor inhibition, we use the mass action term, the interaction of the drug compartment, the drug concentration with the tumor volume. So it causes the reduction in the tumor burden. So our model has now 4 parts, and we need some doing the fitting process. The model calibration. So some parameters we have from the other literature or from our previous publication, but we have two parameters that fitted, and you can see in this figure that there is a good agreement between our model predictions and preclinical data. And our model can capture this nonlinearity in the limb mass behavior based on for different dose amounts. So this is for the daily schedule. And also we looked at the Easton ratio, which is the model prediction, which is the satellite cell over muscle fibers. So it is very interesting that when we have the higher doses, the Easton ratio is higher than the lower doses. So also we have the cachexia in our system, but still the Easton ratio is high. It shows that satellite cells are proliferating, but they are not clear, they are not correctly differentiating to the muscle fibers. And we can say that the myogenesis is impaired in this system. And we also looked at the average exposure of the tissue to the drug concentration. We can see that for the higher doses, we have the higher average exposure, which makes sense. And also we fitted our model parameters to the 5 days on and 2 days off. We can see some oscillations here, which is because of the 2 days off in our drug injection. And then again, our model has a good agreement with the preclinical data. And again, if we look at the stem cell ratio, the satellite cells are proliferating more than that do the correct myogenesis process. And again, we have the higher average exposures for the higher dose amounts. Okay, so after developing our model, we would like to find the optimized dosing schedules to do the chemotherapy. So we investigated standard weekly doses. We assumed 2 different standard doses for daily, which is 28 doses of 24 milligram per kilogram, giving 168 milligram per kilogram total dose per week. And also for 5 days on and 2 days off, we assumed the 35 doses of milligram per kilogram as a standard dose. Weekly should be 175. If we fix these two amounts if we assume these are as two extremes in our case, and then looking at the different schedules, but with different total weekly amounts. We would like to, as I previously also mentioned, we would like to minimize muscle loss, but at the same time also we would like to treat the cancer and then inhibit the tumor. For these different doses amount, if we look at the limb mass and the tumor volume, we can see that the higher doses that we are choosing, like the 56, 57, 58, we have the lower limb mass, and they are causing 10% loss in the limb mass. But at the same time, there is a good treatment in the tumor volume for these higher doses that are higher doses but less frequent. So this is the largest tumor response is seen with those 3 last higher doses. We also introduced another criteria, which is therapeutic efficacy. So this is a total, instantaneous therapeutic efficacy. We compared limb mass over tumor volume. And if we look at here, the highest one, again, are for the highest dose amounts that we have from 56 to the 58, which is the good schedules because they are delivering the most drug in a less frequent time. The another thing, if we want to compare the total effects in our model, we looked at the area under the curve. So we compared different schedules with different dose amounts with the best treatment, which is the 24 daily. So we can see that there is all tested schedules. They are producing smaller limb mass the area under the curve is smaller in comparison with the 24. But at the same time, if we look at the tumor volume, we can see that the tumor treatments is the best response for the higher doses in comparison with the 24 daily. We introduce another, again, the total therapeutic efficacy, which is the division of the area under the curve for limb mass and the treatment. So we can see that, again, the total therapeutic efficacy is much better for the higher doses that are injected in the less frequent time. Then we also tried to find other schedules to see in order to decrease the tumor burden and also keep the limb mass. We separated these dose amounts during the day. For example, you can during the week, we can see that, for example, 4 days on, 1 day off, 1 day on, and 1 day. We actually separated the doses during the week and then looked at the different response of the limb mass and the tumor volume. And we can see here that separating the doses across the week preserve limb mass because the limb mass is a little bit higher, but also decrease the tumor response to treatment. We can see that the tumor is still higher. And but delivering treatment every other day, like for the last 2 doses, which is 48 and 50, has better tumor control in comparison with the others. So if we look at the total therapeutic efficacy and compare the different doses, we can see 43 milligram per kilogram for 4 days on and 3 days off is the best treatment schedules that we can consider. Again, it is about the highest doses, but less frequent time. Another schedule is the metronomic schedule. So in the metronomic schedule, the idea is that we would like to deliver different multiple doses per day in order to maintain the constant level of the drug in body and also at the same time reduce the toxicity instead of giving the injecting the whole drug at the moment. So we try to separate the doses. So we looked at the limb mass, we looked at the tumor volume. So the limb mass is a little bit improved because if you look at this, for example, 3 times of 8 milligram dose injection or the others, we can see a little bit improve in the limb mass. But at the same time, we can see the tumor volume is higher if we compare with the 24 daily and 35, 5 days on and 2 days off. So there is a less tumor control in metronomic schedules, but a small improvement in limb mass. So we can see that the total therapeutic efficacy is not good enough for the metronomic schedules because the 5 days on and 2 days off is higher than the metronomic. So it is not a good schedule. Next step, we looked at the cachexia in aged mice. We simulated 2 different mice, 6 weeks old and 2 years old. So how we simulated these different ages, so we changed the initial parameter values and also we changed the perturbation parameters in our model in order to simulate 2 years old mice. So in this bar chart, we can see that there is slightly less muscle loss in aged mice in comparison with the young mice because bar charts are higher in comparison and all they are normalized by 24 daily doses. So if we look at the tumor volume, there is no effect, age effect in the tumor control. So we couldn't see in our model. And at the end, we can total therapeutic efficacy is the highest dose amount that we have and in less frequent time, 168 milligram per kilogram, 1 day a week and 6 days off, which is the highest injection, the higher amount of the dose injected once a week. At the end, we looked at the morphine injection concomitant with 5-fluorouracil. So as you know, morphine is very potent opioid, but it reduces the pharmacokinetic of chemo agent transit and clearance by 35%. By knowing this fact from biology, so we simulated the morphine injection in our model. So we looked at the limb mass for fluorouracil concomitant with the opioid. So we can see something dangerous is happening because the limb mass is so lower when we are injecting the morphine to the patients. But if we look at the tumor volume, there is great tumor treatment when we have the morphine injected with the fluorouracil. If we compare the total therapeutic efficacy, we can see again that it is great for 168, the highest dose amount that we can have injected once a week. So in summary, we can say that the best treatment response, as you saw in different slides, so the best one is the most drugs that are delivered in the shortest amount of time. The highest dose amount in the shortest amount of time. No significant age-related differences. They were captured by the AUC measurements. There is also inadvertent interference between painkiller, like morphine drugs, and chemotherapy regimes may exacerbate both on-target and off-target. It can exacerbate the muscle loss, but at the same time, it is a good treatment in the tumor. So defining an optimal schedules consists of weighting balance between improved tumor control and preserving limb mass, which is as a main side effect of the chemotherapy. Okay, at the end, I would like to thank Dr. Wilkie because this work was completely done under her supervision. And I would like to thank the organizer of this conference. And thank you so much for your listening.